important role in the onset, treatment, and also prevention of many GI disorder. Yeah? And medical nutrition therapy is necessary to prevent and treat malnutrition associated with the diseases of the gastrointestinal tract. Okay, so this is the assessment parameters. Yeah, what you should do, yeah, when you get a patient, yeah, complaining about digestive disorder. Of course, yeah, we need to assess on their nutrition history. Yeah, among the most important, yeah, yang terlibat lah dalam assessment parameters in digestive disorder is we must assess whether there is any changes in appetite. We know that people with digestive disorder, they syndrome have they always, yeah, have changes in appetite. They feel that they easily feel satiety, kan, rasa tak nak makan, tak lalu makan, ya. Some may experience vomiting, nausea, diarrhea, yeah. They may show problems in chewing and also swallowing, yeah. Some may experience food intolerance, yeah. Then we need to assess about their typical intake, any changes in their diet yeah, that leads to the problems in the digestive system, yeah. Is there any constipation present, yeah? And then we should estimate their nutritional requirement and then plan for their nutrition care. Okay. So the most important indicator here is if there is any unintentional weight loss. So how to measure the unintentional weight loss is we can measure by the percentage of weight loss in specific period of time. Yeah, ada berapa persen weight loss waktu tu? Is it significant? Yeah, is it not significant? Yeah, because we know that early nutrition support will greatly benefit the patients. Yeah, and for the laboratory parameters, among the laboratory parameters that we can look at, we can look into the vitamin, we can look into the folate, ferritin, vitamin, even though we can look at the protein, yeah, we can look at others as well. Yeah, but laboratory parameters, it can be an indicator also for any digestive tract disorder. Okay. Okay, so now we'll move into the disorder, yeah, the disorder of each of the our upper GI tract. Yeah, so the symptoms of esophageal disorder, yeah, it range from the difficulty of swallowing. There's a susah nak telan, yeah, and then also there's a sensation of something is stuck in the throat, yeah, to heartburn and the reflux. This is all among the symptoms of disorder of the esophagus. This is our a nice diagram on the esophagus. Yeah, so esophagus, its function is to convey the solid and liquids from the mouth to our stomach. So our esophagus is highly muscular. Yeah, you can see that this is the esophagus. It is highly muscular. Yeah. So as the bolus of foods is moved voluntarily from the mouth to the pharynx, the upper esophagus sphincter will relax so that the food can move into the esophagus. So there is a peristaltic wave, move the bolus down the esophagus, and when the LES relaxes, so the food bolus can pass into the stomach. So this is the picture, yeah. So actually swallowing, yeah, it is a complex series of events characterized by 3 basic phases. Yeah, later I will explain about the basic phases of swallowing. So actually swallowing is a complex series of process. We think that swallowing is easy. Ya? Kita dah biasa, kita dewasa. Kita nak telan makanan, kita minum air telan, kita rasa senang. Yeah? But actually it's a complex process for some people. Yeah? For example, for elderly, nak menelan tu bukan benda yang senang. And then for kids also, ya. Tengok kids kan, baru nak belajar menelan susah untuk diorang kan. Yeah, because it's actually a complex process. Yeah. So for those who have impairments in swallowing, yeah, they can have a profound impact on intake and also nutritional status. And this can greatly increase the risk of aspiration and its complication of bacterial pneumonia and also bronchial obstruction. Okay. So this is a picture of our swallowing process. Yeah, There are 4 phases here, which starts from the oral preparatory phase, the oral transit phase. You can see this is gambar ni kan. This is the oral preparatory phase, yeah. And then here, when the food is here, it is called as oral transit phase. When the food is at the pharynx, it is the pharyngeal phase, and then it is at the esophageal phase, yeah. So this is all the steps of swallowing, the basic process, yeah. Basic phases of swallowing. Okay, so here explain about the 3 basic phases of swallowing, from the oral phase to pharynx phase and to the esophageal phase. Yeah, so starting from the oral phase, bila makanan tu masuk, kita imagine lah, you ambil makanan, you kunyah. Yeah, so during the solid phase, it is when the food is swallowed, yeah. The food is chewed, yeah, and mixed with saliva to form a bolus. Yeah, so our tongue propels the liquids and food to the back of the mouth to start the swallowing process. Yeah. So kalau dekat sini kunyah, and then kita cuba untuk telan lah, and then it will goes into the pharyngeal phase. Yeah, so during the pharyngeal phase, the foods and liquid bolus pass through the pharynx into the esophagus. Yeah, so kalau ada any impairments here, yeah, possible symptoms of impairment, it may include that food sticking in the throat. Kita rasa makanan tu tersekat, kan? So when there's a food that stick in the throat, yeah, there will akan terbatuk-batuk lah, ya, choking sensation ataupun drooling, airnya tak berhenti meleleh, kan. Yeah, so coughing before, during or after swallowing, yeah, that can lead to aspiration pneumonia. Yeah. And then food supposed to move into the esophageal phase, yeah. So the bolus will pass through the esophagus into the stomach via peristaltic movements. Yeah. So any difficulties with solid food here in the esophageal phase, it can lead to heartburn, yeah, or vomiting, yeah, ataupun burping tak berhenti, yeah. So this is the possible symptoms lah if there is any impairment occurs at these 3 phases, yeah, whether it's oral phase, pharyngeal phase, or esophageal phase. So we know that when there is any impairment occurs during the swallowing, lama kelamaan kalau benda ni berlarutan, it can lead to weight loss. Why? Because the food cannot properly digest. Yeah, so we cannot absorb the nutrient from the food. Yeah, jadi weight loss, malnutrition, yeah, benda-benda tu yang kita tak nak berlaku lah. Okay. So dysphagia, we are talking about swallowing problems. Yeah, so bila dia ada swallowing problems, so we call it as a dysphagia. Yeah, so dysphagia is actually not a diagnosis but a symptom caused by a variety of disorder. So what caused this? What disease and condition that is associated with dysphagia as listed here? Yeah, people can be diagnosed with dysphagia due to the acute neurological disease, such for example, the people have stroke or closed head injury, so they cannot swallow. Yeah, so they have dysphagia symptom. Or people with chronic neurological disease, such as those with Parkinson, Alzheimer, neuropathy disease, yeah, also can have dysphagia symptom. Yeah, those with muscle disorder, those with GI disease, malignancy, and other disorders such as inflammation, yeah, post-intubation injury secondary to tumor, aspiration, esophageal paresis, yeah, drug side effects, and also aging, yeah, also can have the symptoms of dysphagia. Okay, so for those with dysphagia, they have difficulty in swallowing, yeah. So the nutrition implication, it will lead to weight loss and also nutrient deficiency that results from inadequate dietary intake. Yeah. So among the common nutrition diagnoses include inadequate oral intake, inadequate fluid intake, malnutrition, yeah, inadequate protein energy intake, altered GI function, and also swallowing difficulty. So sorry, there's a problem kat sini ya. Kenapa berulang-ulang? Okay. Okay. So for the nutrition intervention, yeah. So the goal of nutrition therapy for dysphagia is actually to modify the texture of foods. Yeah, ataupun kita also nak modify the viscosity of the liquids. This is to enable the patient to achieve adequate nutrition and hydration while decreasing the risk of aspiration. Yeah, so this is our nutrition intervention. So because we want to modify the texture of food, yeah, so kita foods like macam pudding-like consistency, yeah, that are smooth ataupun puree yang tak ada lumps, yeah, this is more suitable for patients with dysphagia symptom. Yeah, and then moist or soft texture such as finely diced meat, yeah, soft cooked vegetables, soft fried food, moistened cereal, yeah, and we want to avoid hard foods, sticky or crunchy items. So you just imagine lah orang tua ataupun baby ya, baby yang baru nak belajar menelan ya, we cannot give them very hard foods ataupun sticky food because we afraid that the food will stick into their throat ataupun dia tak boleh telan ke ya. So we modify the food lah into something like very smooth, puree kan, macam bubur tu lagi halus kan, so that's type of food yeah, that what we suggest to those with dysphagia symptoms. Okay, so the American Dietetic Association, yeah, they has published the National Dysphagia Diet. Yeah, so this National Dysphagia Diet, such as in this table, is actually developed by a group of dietitians, language therapists, and also speech therapists, and also the food scientists. Yeah, so this is the National Dysphagia Diet is established for the purpose of standardizing the dysphagia diets. Yeah, so this dysphagia diet is actually composed of 3 levels of solid texture, yeah, and also liquid consistency. Yeah, ada 3 levels of solid texture. Untuk liquid pula dia ada 4 liquids consistencies. Yeah. So you can look at the table here, yeah. So the level of solid food and liquids, they are ordered separately. This is to allow the maximum flexibility and safety in meeting the patient's need. Yeah. So our patient, yeah, yang ada dysphagia, they may start their dysphagia diet at any level, yeah, any level that's up to what they can tolerate. Yeah. So you can look at the table here, yeah. The solid food, it consists of puree, yeah, mechanically altered, and a more advanced consistency of mixed texture. Okay, while for liquid, they are described as thin liquid, where we allow all liquids, including water, yeah, ice, milk, yeah, or nectar-like, honey-like, or spoon-thick liquid. Yeah. So kalau liquid ni, we always start with liquid, yeah. So any unthickened beverage and supplements are allowed, yeah. And then they can move to honey-like, yeah, nectar-like, yeah. So nectar is thicker than water, but they are thin enough to be sipped through a straw, yeah. Or they can start at honey-like, yeah, macam honey lah. So honey is liquids that can be eaten with spoon, yeah, but they do not hold their shape. Or spoon thick, yeah, spoon thick is more like pudding consistency, yeah, that need to be eaten with a spoon. Yeah, so this is a panduan lah, yeah, the guideline for dysphagia diet, yeah, yeah. Just remember that the patient may start at any levels, yeah. Okay. So that is about the dysphagia, yeah. Okay, now we look at the GERD. GERD is gastroesophageal reflux disease. Yeah, so GERD is complication resulting from the backward flow of the stomach, of the duodenal contents or both into the esophagus. So you just imagine that food is already into your duodenal or into the stomach, and then it's backward flow. GERD lah, macam tak termuntah lah, dia naik balik atas. Yeah. So the symptoms include the burning sensations of the meals, heartburn, dysphagia, and also increased salivation. So that is GERD. Yeah. So you feel like lepas makan tu kan rasa macam pedih perut kan, sakit kat ulu hati, ya. And then air liur tiba-tiba rasa banyak, increase salivation, yeah. So that is good, yeah. Backward flow of the stomach, yeah. Yeah. So under normal conditions, yeah, the atmosphere pressure is greater in the esophagus than in the stomach, and this pressure is typically prevent the reflux of gastric contact. Ya, tapi bila ada our LES, lower esophageal sphincter is incompetence, it may cause GERD. Yeah, so the possible so the symptoms including tadi lah yang macam saya cakap lah, the symptoms including rasa macam nak termuntah, tiba-tiba rasa melonjak naik lah makanan tu balik kan, ya. So what can we suggest to the patient? Possible discomfort during and after eating. So because it can be related to possible discomfort during and after eating. So change in eating habits may help to prevent GERD. Apa maksud change in eating habit ni? Maksudnya tukar gaya makan, jangan makan terlalu laju, because you want to avoid this GERD. So do not lie after eating, position makan tu elok, jangan sampai bersandar ataupun jangan sampai baring, so that is among ways to avoid GERD. Okay. Here is the possible mechanism involved in GERD. So you can look at this picture. Macam apa maksud dia healthy and also those with GERD. So this is the healthy stomach from the esophagus. So the LES, the sphincter will close bila makanan tu dah masuk dalam stomach. However, to those with GERD, the sphincter will open. So it will allow reflux, dia boleh naik atas balik lah. Okay. So among the possible mechanism involved include decreased salivation, transient LES relaxation, reduce the LES pressure, impact esophageal acid clearance, increase esophageal sensitivity, acid pocket. Acid pocket is a normal physiologic phenomenon that occurs in all people. Not as sometimes thought just in people with GERD. So essentially, the food that a person eats, it will neutralize gastric acid, but soon afterward, within 15 minutes, the stomach will secrete acid in response to that food. So this newly secreted acid layers on top of the meal. So it does not mix with the meal, which resulting in a region of top on the food. This is what we call as acid pocket, which is highly acidic. And then among other possible mechanisms include increased intra-abdominal pressure and also delay gastric emptying. So we can see that macam mana gambar dia kat sini kan, GERD. So that's why kalau kita makan terlalu banyak or you just eat binge eating ke, kan also can be a possible penyebab lah untuk GERD here. Okay. So this is some of the factors that can lower the LES pressure and lead to LES incompetence. So due to the increased secretion of the hormone gastrin, estrogen, and also progesterone. When there is a presence of other medical conditions such as hiatal hernia and also obesity, and then those who are smokers, also can have risk to have LES incompetence, use of certain medications and also specific foods. So some foods, they may trigger GERD because they may decrease the LES pressure. For example, foods that are high in chocolate, spearmint, peppermint, alcohol, caffeine, it may decrease the LES pressure. But it may not be true for certain people lah. So we have to ask our patient lah apa yang dia makan, what is their diet, that can lead to these problems. Okay. So how about the nutrition therapy? So the common nutrition diagnosis, including overweight or obesity. So orang yang overweight dia lagi biasalah ada digestive problems. Impact nutrient utilization, yeah, inadequate vitamin or mineral intake, swallowing difficulty or altered GI function. Yeah, and then of course we need to perform nutrition assessments, such as I mentioned before. Yeah. So how about the treatment? The treatment include lifestyle modification, and here it's include nutrition. Yeah. Drug therapy and also surgical intervention. So our nutrition intervention is back to our nutrition assessment. What is our nutrition diagnosis? So we tackle from there. Yeah. So generally, we want our patient to avoid foods that may cause symptoms. So that's why it's important for you to identify, yeah, to probe the patient, yeah, what food that may cause the symptoms of GERD. Yeah, is there any foods that may relax the LES? Yeah, ataupun food that may increase gastric acid secretion, such as coffee, alcohol, or pepper. So basically, if they consume foods that may cause the symptoms, so they need to avoid the foods. Maybe need to avoid the food for a while until the symptoms resolve, or perhaps they need to always avoid the food lah, or else they will develop GERD. Okay. Here is the table that summarize, yeah, on foods to avoid. Yeah, yeah. Sama juga macam tadi lah, ya, nutrition intervention. So we suggest the patient to avoid peppermints, chocolate, yeah, fried food, or those with high amounts of added fat. Yeah. Fried food ni tak semestinya goreng je lah, macam makan nasi yang bersambal, nasi goreng, nasi lemak. Also they may need to avoid for a while, yeah, because it is contain high of fat. Yeah. Alcohol, coffee, yeah. Coffee other than they may relax the LES, they may also increase gastric acid secretion. Yeah. And this table, it shows that foods to avoid if they cause symptoms. Yeah, so not everyone not tolerate to this food. Yeah, so unless, yeah, they cause symptoms of GERD, so they need to avoid this kind of food lah. Yeah, including caffeinated drinks, yeah, milk or dairy products. Yeah, then high fat choices. Yeah, some people they may have intolerance to meat. Yeah. Vegetables, some people may have symptoms, yeah, when they eat vegetables, especially those vegetables with high gas production, yeah, macam broccoli, cabbage. Yeah, we know that kind of food may produce high amount of gas, right? And then fruits, yeah, perhaps kalau ada fruits that can aggravate the symptoms, yeah, fat and also dessert and other food lah, misalnya, yes, such as pepper, yeah. So basically, we just back to our nutrition assessment, what foods that can trigger the GERD, yeah. So they need to avoid that. Okay. Okay, clear, ya? Kita dah sampai, we touch about the dysphagia, about difficulty in swallowing, yeah, and then we look into the GERD. Okay. Okay. Now we look into the esophagitis. Yeah? So esophagitis is the inflammation, ulceration, erosion, or scarring. Yeah? It's actually macam prolonged acid exposure. It also can result in esophagitis. Yeah? So acute esophagitis may be caused by reflux, ingestion of a corrosive agent, infection, intubation, radiation, eosinophilic infiltration, and the chronic esophagitis from prolonged contact with gastric acid or other irritants. Yeah. So symptoms of esophagitis and GERD, yeah, it may impair the ability to consume an adequate diet and interfere with sleep, work, social events, and overall quality of life. Yeah, so those with GERD, bila makan je dia rasa nak muntah, kan, dia rasa perut penuh, ya. So it may impair the ability to consume adequate diet because the people might not want to eat, yeah, because dia rasa bila dia makan je dia rasa nak muntah, kan. Yeah. And then Barrett esophagus is the precancerous condition that can also affect the esophagus, and it only results about 5 to 15%, yeah, of the esophagitis. Okay. Okay, this is the Barrett esophagus. Yeah, it's actually the precancerous condition which can be detected by endoscopy, yeah, and precursor to malignancy. So there is no specific symptoms for Barrett esophagus. Yeah. And the risk factors include prolonged GERD, male gender, age older than 50 years, family history, and there is an increasing incidence of Barrett esophagus, yeah, and higher risk of adenocarcinoma of the esophagus. Okay, okay. Give me a while. Okay, I need to reply this. Okay, next. Okay, so here is the summary point. Point form on the nutritional care guideline for patients with reflux and esophagitis. Okay, sama juga macam tadi basically those yang ada problem in upper GI disorder they might need to avoid large and also high fat meal. Jangan binge eating, jangan makan terlalu banyak jangan sampai makan sampai perut penuh sangat lah then avoid eating at least 3 to 4 hours before retiring. Macam you want to sleep at 10, so stop eating about 3 to 4 hours before that. And then elevate the head of bed by 6 to 8 inches for individuals who have reflux episode at night. Tidur baring, bantal tinggikan sikit. Avoid smoking, avoid alcoholic beverages, avoid caffeine containing foods and beverages. Stay upright and avoid vigorous activity soon after eating. Avoid tight-fitting clothing, especially after a meal. Consume a healthy, nutritionally complete diet with adequate fiber. Avoid acidic and highly spiced food when inflammation exists, and lose weight if overweight. I mean, you see that all these 11 points, this very basic point kan, but inilah dia sebenarnya the nutritional care guidelines, our guideline to those patients with reflux. Okay. Any questions so far kat sini? Ada yang tak faham tak? I hope we are clear pasal apa GI problem is very straightforward sebenarnya So kalau dapat patient yang macam ni just assess apa benda yang dia makan, so just our consultation is based on this point lah avoid food that may trigger reflux, and then ask them to avoid binge eating and we can also plan for weight management strategy if the patient is overweight. So you can see that point number 8 avoid tight-fitting clothing So kata yang itu yang pasal kalau orang yang ada GERD ni kan, orang biasa pun lah kalau hari raya jangan pakai baju ketat kan, nak makan banyak kan, so because it can trigger GERD also. So we finish about GERD. Now we look into the hiatal hernia. Okay, so what is hiatal hernia? This is a picture of those with hiatal hernia. This is an outpoaching of a portion of the stomach into the chest through the esophageal hiatus of the diaphragm. So the symptoms of hiatal hernia is actually they are consistent with those in GERD. So the nutrition intervention are actually similar with GERD. All tadi 11 points tu is similar lah with those with GERD and those with hiatal hernia. So the most common symptoms is heartburn. Then we feel epigastric discomfort after large and also energy dense meal. Then medical nutrition therapy also include weight reduction and also decreasing in meal size. And those with hiatal hernia, they may require surgery. These are 4 types of hiatal hernia. So type 1 this is type 1 hiatal hernia. This is the normal esophagus So this is type 1 hiatal hernia, which is the most common type. Is sliding sliding hiatal hernia. So for the type 2 it will slide upward lah kat sini and move to the GI junction. This is type 3 this is type 2 and this is type 3 lah. This type 3 is actually any combination of type 1 and type 3. Dia sini sikit and then dia naik ke atas ni. macam sliding kat sini lah, this is type 3. Okay. Yeah. Dia ada 4 types sebenarnya ya. Kalau yang 4 types 4 tu dia less common lah ya, which can involve other organ. Macam dia can involve the colon or it can involve the small bowel ya, into the hernia side. Okay. Okay. So hiatal hernia, the medical nutrition therapy, it is as similar as GERD ya, GERD. Okay. Now let's look at the cancer. Yeah. Cancer of the mouth and esophagus. This is also type of digestive tract disorder lah, but of course lah, kalau cancer and surgery, it also falls under other nutrition therapy as well. Yeah. So the primary indication of esophagectomy is the esophageal cancer or Barrett esophagus. Yeah. So existing nutritional problems and eating difficulties caused by the tumor mass, obstruction, oral infection, and also ulceration. Yeah. So chewing, swallowing, salivation, and taste acuity are often affected, and weight loss is also common in the cancer of esophagus. Okay. Okay, give me a while, yeah. Okay. A moment, yeah. Okay, sorry. Okay, and because I actually have another meeting session, yeah, I just off and I just give my lecture here. Okay, so we continue here. Yeah. So that's about cancer and the surgery of mouth and esophagus. Yeah. So now we look at the MNT for esophagectomy. Yeah. So the nutrition assessment, we should assess any history of weight loss and also swallowing ability. Yeah, you will learn lagi lah nanti dalam cancer, MNT for cancer macam mana. Yeah. So nutrition assessment, we assess the history, any weight loss, any swallowing ability. Yeah. So we look into the, kalau kita tengok pasal esophagectomy and also MNT surgery, yeah, we tengok dekat dia punya perioperative phase. Yeah. Is there any dysphagia? Yeah, because however dysphagia is common for people with Barrett esophagus, yeah, atau esophagus cancer. Yeah. So our diet, it consists of soft diet. Yeah, soft diet macam makan bubur lah, makan bubur, pudding like consistency, semua tu namanya soft diet. Yeah, and we also suggest on calorie dense, yeah, ONS, yeah, oral nutrition supplement. Yeah, this is actually to maximize energy intake. Yeah, nasoenteric feeding may be necessary if the patient cannot eat. Kalau kita memang ada masalah dekat esophagus, tak boleh telan, perhaps we need to suggest nasogastric feeding lah. Okay. Okay. And during the post-operative phase, yeah, if there is any gastric pull-up procedure, yeah, gastric pull-up procedure is the removal of a segment of the entire esophageal tract, yeah, and we replace it with the stomach tissue, yeah. So the risk of complications including aspiration, dysphagia, anastomosis leak, wound healing, and also stricture. Yeah. So jejunal feeding may be needed until adequate oral intake is achieved. So let's say if after the operation the esophagectomy, so perhaps we need to give a jejunal feeding, yeah, feeding that is directly goes to the jejunum, yeah, tak masuk melalui atas lah, masuk terus kepada jejunum, yeah, until oral adequate intake is achieved, yeah. And then transition to oral intake, yeah, from the clear liquid to soft and also moist diet. So actually progression daripada tube feeding, daripada dia nak pergi jejunostomy kepada nasogastric ataupun kepada oral diet, dia akan ambil masa yang lama lah. It may take about 6 months for this kind of patient. Yeah? So when they can start to eat oral feeding, we should suggest them to eat small and frequent of meals and limited fluid at meal time, yeah, because we don't want the patient to be full ataupun kita tak nak juga kacau dia punya swallowing ability, yeah. And then some may experience dumping syndrome. What is dumping syndrome? Yeah, dumping syndrome, yeah, which can be categorized by abdominal pain, nausea, diarrhea, weakness, and dizziness. Yeah, if the food pass into the small intestine. too quickly, because this patient masa dia when they get their food through jejunostomy ataupun tube feeding, dia mungkin makan biasa sikit kan, dan suddenly nak makan banyak, tak boleh lah sebab tak nak ada dumping syndrome. Okay. So we finish about the disorder of esophagus, ada daripada tadi start daripada dysphagia, GERD, hiatal hernia, and kita tengok without the cancer of the esophagus. Now baru kita tengok kepada disorder of the stomach. Okay. So kita tahu fungsi perut kita, it accommodates and store meals. Makanan yang kita makan, kita pun biasa kata kita masuk kepada perut. So the stomach, it accommodates and store meals. So basically indigestion or dyspepsia is the epigastric discomfort after meal. So lepas ni kalau makan banyak rasa senak perut kan, rasa perut penuh kan, tak cakap sakit perut, cakap ada dyspepsia, ada indigestion, sedap sikit bahasa dia. Okay. So our gastric volume ni, perut kita ni sebenarnya kecil je, is approximately about 50 ml only when empty. Bila empty, lebih kurang 50 ml, kecil rata je. But when we eat, it can expand to approximately about 4 liter. So dyspepsia ni is actually refers to the persistent upper abdominal discomfort or pain. The feeling of abdominal pain, bloating, early satiety, nausea. This is the symptoms of what we call as indigestion or dyspepsia. Underlying causes may include GERD, peptic ulcer disease, gastritis, gallbladder disease, or other identifiable pathologic condition. So what we should do for those with dyspepsia yang ada indigestion, they may reduce dietary fat intake, use smaller meals, eat meals with low caloric density, and also limit alcohol. So perut rasa full lah. Sometimes orang kita paling senang lah kan, dia rasa kan bila dyspepsia ni, dia minum inu. This is what I always do lah. Baru rasa lega sikit lah, buang angin. Okay. So, and then you look into the nausea and vomiting, which is the common symptoms as well with people with stomach disorder. So, both nausea and vomiting are controlled through the same neural pathways. So, nausea ni rasa macam nak muntah lah. This is unpleasant sensation that there is a need to vomit. While vomiting is muntah lah, kita keluarkan balik the gastric content. Okay. So, it occurs with many different medical conditions. Whether it's infection, pain, pregnancy, syncope, headache, metabolic disorder, motion sickness, myocardial infarction, etc. So actually nausea and vomiting ni dia bukan simply like rasa muntah sakit perut, because it can be related to many other different medical conditions lah. Some people may experience vomiting too just because of indigestion. Some people it may indicate other serious condition. So the treatment, if underlying causes, is the most important step lah. Okay. So what is the nutrition implication of vomiting over and over again? Of course, they will lead to inadequate nutrient intake. Dehydration, banyak sangat muntah kan, acid-base imbalance, and also food aversion. And then the nutrition diagnosis, the common nutrition diagnosis include altered GI function, involuntary weight loss if any, inadequate fluid intake, and also inadequate oral intake. Okay. So here is the nutrition intervention. So our nutrition intervention is we want to minimize the symptoms and also discomfort. Usually cold foods and minimal smells are best tolerated. daripada makanan panas, minum sejuk biasa je lah. And minimal smell, usually those with nausea and vomiting tak nak dah makan kari ke, makan gulai ke, tak nak lah even makan pedas yang bau sangat kuat tu, usually they are not well tolerated with people experience nausea, vomiting lah. So they can try liquids after vomiting has stopped. Any liquid, we suggest like plain water. You can try juice or sport drinks, tea, lemonade. Then we can introduce solid after there has been no vomiting. Add one solid food at a time in very small increments. And we try to avoid foods that high in fat, fiber, strong odor or gas producing. So try solid, you can try makan porridge ke, any pudding like consistency, makan nasi pun boleh, ada soup sikit ke kan, when there is no vomiting, when vomiting is stopped. Use of ginger may help, yes. Some people they letak ginger dalam bubur ataupun minum air teh halia kan, and take medications after eating. So this is among the interventions lah, for nausea and vomiting. Okay. Then gastritis. So gastritis is the inflammation of the gastric mucosa or stomach. So H. pylori, Helicobacter pylori, this is actually a negative gram bacteria which is resistant to the acidic environment in the stomach. So the H. pylori is responsible for most cases of chronic inflammation of gastric mucosa, of the peptic ulcer, gastric cancer. So this bacteria is believed to be spread through the contaminated food and water. So this is one of the most common causes to gastritis. So the acute gastritis is the rapid onset of inflammation and symptoms, while chronic gastritis may occur over a period of time. So the symptoms of gastritis, it may include nausea, vomiting, malaise, anorexia, hemorrhage, and also epigastric pain. So I believe lah mesti ada dalam kalangan you all kat sini yang biasa kena gastrik. Maybe you kena acute, maybe you kena gastric. So gastritis is it can be caused by the inflammation of the gastric mucosa. It can be because of the bacteria ataupun it may be because of the inflammation. And nowadays sometimes gastric also can be induced by stress. Stress induced gastric, whether it's stress due to trauma ataupun stress due to emotional distress. Macam rasa stress, depression is also can induce gastric. Okay. Now we look at the peptic ulcer disease. So peptic ulcer disease are open sores that develop on the inside lining of the stomach, and the upper portion of the small intestine. So the most common symptom of a peptic ulcer is stomach pain. So the primary causes is about the similar with gastritis tadi lah. But the peptic ulcer disease is also involved gastric and also duodenal regions. So in the gastric ulcers, it is in stomach, normal or low acid secretion, and duodenal ulcers in duodenum and high acid secretion. So the peptic ulcer ni dia ada open sores. Compared dengan gastritis tadi dia ada inflammation, tapi kalau peptic ulcer dia ada open sores. Okay, so this is the gambar lah of the ulcer. Macam mana ada ulcer, you can see kat sini, ada gambarnya kat sini, ada sore, ada luka lah macam tu kat sini. This is the gastric ulcer kat sini, bahagian sini, and this is the duodenal ulcer here. Okay, so to compare between gastric and duodenal gastric ulcer formation, it involves widespread gastritis, inflammation of oxygenated cells, and atrophy of acid and pepsin producing cell, while duodenal ulcer are associated with high acid and low bicarbonate secretion. So hemorrhage and increased mortality are associated with gastric ulcer. Yeah. Tengok baliklah gambar ni for you to understand better about the gastric and also duodenal ulcer. Okay. So the management of peptic ulcer, the medical management including antibiotics, acid suppression, surgery, and also stress reduction. Yeah. So like I mentioned lah, yeah, stress also can contribute to GI discomfort. Yeah. Okay. Okay. So look at the nutrition therapy. Yeah? So the nutrition implication for peptic ulcer disease, it will give impairment to oral intake. It will result in weight loss and also nutrient imbalance. Okay. So the common nutrition diagnosis include inadequate beverage intake, altered GI function, involuntary weight loss of food, and also nutrition related knowledge deficit. Yeah. So the nutrition intervention, this is among all the nutrition intervention, yeah. Kita nak restrict or avoid food that may increase acid secretion, yeah. Not lying down after eating, avoid eating larger meal close to bedtime, and take smaller and small frequent meal. Yeah. So for nutrition intervention, although dietary restriction are commonly used for ulcer, yeah, however, there is no evidence that diet causes peptic ulcer disease or speeds ulcer healing. Yeah. So kita mungkin akan kita boleh cakap kat patient may be told to avoid coffee, avoid alcohol, avoid chocolate, because this kind of food, they may stimulate gastric acid secretion. Yeah. Yet consuming moderate amount of these items has not been shown to impair ulcer healing. Yeah. So some evidence also suggests that we may suggest patients to take high fiber diet, especially soluble fiber, yeah, that may reduce the risk of duodenal ulcer. Yeah. But other dietary factors including alcohol and caffeine have little effect on the ulcer risk. Yeah. So nutrition intervention, it may play a supportive role in the treatment by helping to control the symptoms. Yeah. So it depends much on the patient itself whether caffeine, chocolate, it is that kind of food may trigger their pain or not. Yeah. Okay. Then stress ulcer. Stress ulcer is complication of severe burns, trauma, surgery, shock, radiation therapy, or renal failure. Yeah. So this is a significant cause of morbidity in critically ill patients. Yeah. So use of antioxidant compounds show promise. Okay. Okay. Then carcinoma of the stomach. Yeah. Cancer of the stomach. Yeah. So when there is a cancer, yeah, usually surgical resection or gastrectomy is performed. Yeah. So prevention of GI cancer, is hard to say prevention of GI cancer once, because we can say how to prevent cancer, can. Yeah. However, we can try by practicing healthy diets. Yeah. High intake of fruits, vegetables, and selenium, they may be related to reduce the event of cancer. Yeah. So and things that can increase the risk of cancer, including alcohol intake, being overweight, high salted or pickled foods, and also inadequate micronutrients is related to the cancer. Okay. Then gastric surgery, yeah. Bila nak kena buat surgery ni, yeah. So when people with peptic ulcer disease, yeah, they are not respond adequately to the medical treatment, ataupun when patients experience a complication of peptic ulcer disease, yeah, surgery is often the next step. Yeah. When there's a complication, yeah, macam hemorrhage, perforation, obstruction of pyloric sphincter, dumping syndrome, yeah. So when there is a gastric surgery, the nutrition implication including reduce the capacity of stomach, yeah, potential changes in gastric emptying, valuable components of digestion may be altered or lost, and potential vitamin and mineral deficiencies. You know that when you remove part of your gastric, right? So maybe some of the vitamin cannot be absorbed efficiently. Yeah. some digestion altered, digestion process are altered or lost. Among the common nutrition diagnoses include increased energy expenditure, inadequate oral intake, inadequate protein intake, inappropriate intake of carbohydrate, altered GI function, impaired nutrient utilization, involuntary weight loss, and food and nutrition related knowledge deficit. So the nutrition intervention include anti-dumping diet. Please read about dumping syndrome. So kita anti-dumping diet. So we avoid simple sugar, lactose, and consume liquid between meals. We suggest on small and also frequent meal. And then for the monitoring and evaluation, we monitor closely for weight loss and symptoms. Any symptoms related to malabsorption and also steatorrhea. Okay. So this is among the gastric surgical procedure. Banyaklah gastric surgical procedure where you want to remove parts of your gastric. Ni nama-nama dia lah. This is the gastroduodenostomy, gastrojejunectomy. You remove parts of your jejunum. This is you remove at the duodenum part. This is partial gastric resection. You remove part of gastric here. This is root and gastric bypass. Sometimes we call it as bariatric surgery. Bariatric surgery, you bypass kat sini. There are a few types of surgical stomach surgical, gastric surgical. So you remove part of your gastric. So apa jadi bila remove part of gastric ni? Your gastric become smaller. So you jadi kenyang cepat. Tak payah nak makan banyak. So lama-lama boleh reduce weight. But remember that this is not really permanent because your stomach even though dia dah mengecil tapi dia still boleh mengembang lagi juga. So kalau orang yang post bariatric surgery ni, if they don't really control their diet, they don't exercise, lama-lama dia boleh naik balik berat badan lah. But basically bariatric surgery is one of the best procedure lah to help people to lose weight, provided that they meet the criteria for them to undergo the bariatric surgery. Okay. Here is the summary of the nutrition intervention post-gastric surgery. We need to prescribe adequate energy and protein intake to ensure appropriate healing and recovery post-operatively. So how about our prescription? We should refer to our guideline surgical surgical guideline of the diet pre and post surgery. We recommend appropriate nutrition support if progression to solid food does not proceed successfully. So usually after surgery kita suggest more frequent meal. We started with liquid diet and then puree consistency. Makan bubur dulu slow-slow lah, and then baru pergi ke solid food. We initiate slow progression of solid food to prevent onset of early and late dumping syndrome. We avoid simple sugar. Kalau diminum air pun jangan start dengan simple sugar. Okay. And then the first meal should consist of protein, fat, and complex carbohydrate, but we only introduce 1 to 2 foods items at a time. So patient may be initially lactose intolerance and dairy food products should be avoided. And then after that, baru kita slowly progress to 5 to 6 meals per day. We advise patient to consume liquid 30 minutes to 1 hour after solid food. Okay, etc. lah. This is the nutrition intervention. Okay. I saw you all baca, tapi ada pula kat sini about the dumping syndrome. Okay. So the nutritional complication of gastric surgery depends on the extent of gastric resection and the type of reconstruction performed. So a common complication of gastrectomy and also gastric bypass is this dumping syndrome. Dumping syndrome is a group of symptoms caused by rapid emptying of stomach content into the intestine. So it is a complex physiologic response to the rapid emptying of hypertonic contents into the duodenum and also jejunum. Yeah. So the dumping syndrome occurs as a result of total or subtotal gastrectomy. The symptoms such as abdominal fullness, nausea, flushing, rapid heartbeat, faintness, sweating, flatulence, abdominal cramps, diarrhea, and also alimentary hypoglycemia. Yeah. So a reduced stomach capacity, rapid gastric emptying, and also rapid transit time, it will increase the risk of maldigestion, malabsorption, and also decrease oral intake. So the excretion of calorie and nutrition, it will produce weight loss, and however, it will also increase the risk of malnutrition. Okay, here is the pathophysiology of dumping syndrome. Okay, I don't want to touch this. Okay. So how about the nutritional care guideline for patients with dumping syndrome? Yeah. So the nutrition intervention, it can control or prevent symptoms of dumping syndrome. Yeah. So patients are started on small frequent meals consisting of protein, fat, and complex carbohydrate. Yeah. However, only one or two items are given in each meal. Yeah. So small meals spread throughout the day are likely to result in improved intake absorption and less dramatic fluid shift. Yeah. So we suggest on high protein, however moderate fat foods. Yeah. With sufficient calorie for weight maintenance or gain. Yeah. And then intake of fibrous foods, it will slow upper GI transit and increase viscosity. However, to avoid obstruction, caution should be used with large particles and fiber supplements. So lying down and avoiding activity an hour after eating may help slow gastric emptying. Yeah? So this is how to slow the gastric emptying lah. We ask the patient to lying down ataupun rehat sahajalah. Avoiding activity after eating. Okay. So taking large amount of liquids with meals is thought to hasten GI transit, but adequate amounts of liquid should be consumed throughout the day and small amounts at times. Only very small quantities of hypertonic concentrated sweets should be ingested, and this includes soft drinks, juices, pies, cakes, cookies, and frozen desserts. Yeah? So lactose may be poorly tolerated because of rapid transit and thus need to be avoided. And cheese and yogurt are likely to be better tolerated, but again, it depends on the patient whether they can tolerate or not. Okay. Okay. Then gastroparesis. Gastroparesis is a disease in which the stomach, they cannot empty itself. It cannot empty itself of food in a normal fashion. Yeah. So it's actually a syndrome of objectively delay gastric emptying in the absence of mechanical obstruction. Yeah. So the symptoms include early satiety, postprandial fullness, nausea, vomiting, bloating, and also upper abdominal pain. Yeah. So it may be due to the abnormality in the hormones, muscle, or the nervous system control of gastric emptying. Okay. So for the gastroparesis, also the nutrition implication is high risk of malnutrition. This is among the nutrition diagnosis, yeah. And for the nutrition intervention, it's included the modification of the oral diet, or if necessary, enteral or parenteral nutrition. Yeah. So that is about the gastroparesis. Okay. Oh, we moved to the focal points. Okay. So recap back, yeah. We for the upper GI disorder, we look into the esophageal disease, and then for the stomach disease, yeah. So apa yang relate dengan esophageal disease tadi tu, yang pasal dysphagia, ya, GERD, ya. So basically benda yang ke atas lah, ya, you rasa nak muntah, everything, that's involved in the esophageal disease. And then the stomach, ya, stomach disease, ya. Semua tu yang pasal gastric carcinoma, gastroparesis, dumping syndrome, etc. Semua tu dekat stomach lah. Yeah. So for the focal point, treatment for disorder of the upper GIT has changed drastically in the past century. So for many years, diet therapy was planned and milk products that were thought to be acid protective. So diet recommendation are now focused on foods that affect LES pressure and gastric emptying time. Yeah. So progress in the medical management of GI disorder has dramatically improved the outcome of the patients. And today, nutritional care for patients with upper GI disorder is specific, individualized, and far more effective than in the past because of increased knowledge of neuroendocrine mechanism, pathogens, and environmental agents. So registered dietitians have many tools and food manipulations available that can enhance gastric surgery and overall treatment. So my point here, when you get a patient with GI disorder, upper GI disorder, so you perform nutritional assessment. So from your nutritional assessment, then you know what to do. Ya, of course lah. Ya, you dah tahu diagnosis daripada doktor. Doktor kata dia apa? Doktor dah diagnose dia ni dumping syndrome ke? Dia ni gastroparalysis ke? Ya, thalassemia ke? Ya. So our tugas our role is to do the nutrition assessment, proper nutrition assessment. So from there only we know that what food that the patient should avoid, what they should reduce, and what they should increase, to prevent from any nutrition related disorder lah. From any from any malnutrition. So that's all for MNT for upper GI disorder. So for self-study, I would suggest you to study about the sample diet for disease. I mean suggest student to study lah. For those with tadi macam national dysphagia diet tu kan, those with dysphagia, apa diet dia nak makan, dia perlu makan apa. Those with apa lagi tadi, those with dumping syndrome contohnya, apa yang dia perlu makan. You can study the sample diet for each of the disease lah. So that's all from me. Any other questions before we end this lecture? That's all. Habis dah.
Sorry doktor, saya nak tanya.
Ya boleh, saya tak silakan.
Hello?
Yes, you can
Saya
ask.
nak tanya, yang table tadi tu doktor refer daripada mana ya? Macam buku ke internet je?
Oh, buku semua daripada Cross. Buku Cross, ya textbook. Ya all ada buku Cross kan, textbook, buku MNT, ada tak? Can you hear me?
Saya tak sure. Kan doktor, saya tak sure ada tak buku tu.
I tulis buku ni. I think this is books that that every student must have sebenarnya. I google sekejap buku ni. Cross Nutrition, Food Nutrition and Diet Therapy. This is the reference book that I use daripada zaman I belajar dulu sampai sekarang. Bukunya as a senior, so I think that most of our student they have this kind of book, daripada MNT 1 lagi kita dah refer kepada this book, Cross Food Nutrition and Diet Therapy. Let's say if you don't have this book, I nak suruh you all beli jugalah, nanti you all akan masuk MNT 3 kan. Kalau tak ada buku reference ni, even daripada zaman I belajar, sampai zaman kerja kan, I akan refer this book. Cross Food Nutrition and Diet Therapy. Tapi buku ni mahal lah. Buku ni I think beratus-ratus harga dia lah. Tapi this is our reference book lah. Jadi kalau tak ada, cuba tanya senior you. I'm not sure whether they have e-book or not. Sebab I pakai buku lah. We can google this book lah. This is our reference book. I'm not sure sekarang ni dah berapa banyak edition. Dah 15, 16, 17 edition kot sekarang This is the book lah that we refer. Ask your senior. I think your senior ada kot buku ni. Okay? Ada e-booknya, bagus ya. Okay.
Okay, thank you doktor.
Okay, welcome. Okay. So if you have any other question, you can just text me, okay? So we continue next week. Yes, we continue next week with MNT for lower GI disorder.